So let's get started. Our speaker today is Dr. Danielle Brown. She's a graduate of USC's dental school, and she was in private practice in Los Angeles until early this year when I was fortunate enough to get her to join our clinical team here at Glidewell. She was selected for the Top 40 Under 40 award from the National Dental Association in 2023, and she completed the Guiding Leaders program that same year. Dr. Hochberg was recently picked to be the top 80 over 80 group. So I think that's a wonderful thing to consider. Okay, and Dr. Brown has a great topic today. She'll be talking about veneer preparations from full prep to no prep. Dr. Brown, I'm excited for your presentation. Please take it away.
So, this is a photo of me and my father. And when I originally was given this topic to discuss, I immediately thought about my dad. My dad's big thing that he would always say to me is failing to plan is planning to fail. And he would say that constantly because he was very much a planner. And I, on the flip side, was very much not a planner. But I immediately thought of him and his saying when this topic came up because this is never more important than when you are planning for an anterior case. Any good anterior case always starts with a plan. And that plan has to start with a really good understanding of where you would ultimately like to end up, where your patient would ultimately like to end up, and a good, thorough understanding of where you are starting so you can know how to get there. And that really helps with our decision making with how we're going to go ahead and prepare our teeth going forward. So, whenever I start any anterior case, the beginning of my plan starts with asking three questions. So, the first question I like to ask my patient is, why are you here? What brings you here today? Is there a wedding coming up? Is there an event that you need to get ready for? Because a lot of times patients have kind of started to see this destruction or they've been unhappy with their teeth for a while. But what is it that led them to decide that now is the time to change that? Because that can really impact the plan that we choose going forward if there's a timing issue or whatever the case may be. So, my first question is, why are you here? The second question I like to ask is, how did you get here? Are you a clincher? Are you a grinder? Did you have trauma? Why are your teeth in the current position that they're in right now? Because again, that also will impact how we prepare our teeth. And lastly, where do you want to go? I had a patient one time who came and I started her process. I did a wax up on everything. We did a mock up. She had spaces between all of her anterior teeth. So I went ahead and I had the mock up done, the wax up done. We put on a mock up that closed all the spaces, increased the length. It was beautiful. I hand the patient the mirror and she immediately stops me and goes, well, what happened to my gap, doc? And I'm like, well, you told me you wanted to close all the spaces. And she goes, no, I don't want to close all of the spaces. All of my family has one gap in between their two front teeth, and I'd like to keep that. I want it a little smaller, but I want to keep it. And it just told me that in that moment, I realized my patient and I weren't going the same place because I didn't stop to ask all of the appropriate questions. So it's very, very important that we take the time to get answers to really all three of these questions to ensure that both you and your patient are on the same road going forward. So the first question that I like to do when I go ahead and get started planning an anterior case, first decision I make is, am I placing crown or veneers? And because dentistry is not really one size fits all, I look at every tooth individually and determine for each individual tooth that I am planning to treat, am I going to treat with a crown or am I going to treat with a veneer? So generally, I like to make this decision with the patient in the chair with me when I can go ahead and utilize my mirror, the radiographs, and I can look and see exactly what I have. But oftentimes, if we are a little crunched for time or I have other patients in the waiting room, I'm not able to do everything in that moment. So what I will do is I ensure that I have adequate radiographs, adequate intraoral photographs, and a good intraoral scan so that I'm able to take time later on and really go over everything. So I'll do it. If I'm able to do the entire diagnosis with the patient in chair, I will. If not, I'll do a little preliminary diagnosis, take a couple of notes for myself, but then really take the time and utilizing all of the data that I gathered and go over each tooth one by one. I find that answering this one simple question to start with really takes a lot out of my decision making. Because realistically, if we're looking at a crown, for the most part, the prep is pretty simple. If we're looking at veneers, now I have to answer a few more questions, but answering this one question makes a huge difference for me. Obviously, there are times where I've gone ahead and said, I'm going to do a veneer on this tooth, but the decay ends up being a little more extensive, or we have other issues. So it ends up being a crown, and that's fine. But this at least gives me a good starting point before I begin to kind of touch any of the teeth. So before we discuss veneers, we're going to start by discussing some crown indications. So there are some areas and some situations where I will absolutely not even consider a veneer. So the biggest one for me, if the patient or the tooth in question has a previous root canal on it, I 100% am going to go ahead and restore that tooth with a crown. I know that as biomimetic dentistry is really kind of picking up steam and people are approaching things with a little bit more of a conservative approach, a lot of doctors are pulling away and are just kind of doing more cuspal coverage, but not full coverage restorations. I'm a little more conservative in that respect, a little more old school. In my mind, removing the nerve removes the nutrient source. The tooth is more brittle. It's just more predictable in my hands, and I feel a little more comfortable restoring any root canal treated teeth with a full coverage restoration. Any patients that come and they have large existing restoration, so they're coming with class 3 or class 4 fillings, there's a little bit of a structural compromise, I'm automatically going to consider a crown over a veneer. Patients where they have severe malocclusion, or patients who have insufficient enamel. So if the patient has a history of GERD or habits that have led to erosion of their enamel, whenever we're placing veneers, we really want to rely on the strength that we get from enamel bonding. So if the enamel is really compromised, I will go ahead and restore the tooth with a full coverage restoration. Patients who are bruxers, I'll go ahead and place a crown. Extensively damaged teeth, so any kind of trauma, I'm going to go ahead and place a full coverage restoration, generally speaking. And any case where we have significant tooth discoloration. So we've all been in that scenario where we're a little optimistic and try to kind of change the shade of the tooth several shades by using veneers. Sometimes we're successful, sometimes we're a little less successful. And I just find that in areas where we have extensive discoloration, so if I'm trying to change the shade by more than 3 shades, typically speaking, because of the thickness of the restoration of the crown, I find that I'm better able to predictably block out those darker stump shades. So if I am kind of trying to correct severe discoloration, I'm going to go with a crown more often than not. So there are a few things that I like to consider when I'm actually looking at the photos or the radiographs. So I'm looking at large carious lesions. So if we look at this first picture on the top left, you can see there's a large interproximal carious lesion. So in that case, I am going to go ahead. This was actually much more extensive than it looked on the radiograph. So this tooth ended up being restored with the crown. If we look at the second radiograph, this one was actually pretty interesting. So this patient has existing interproximal composite restorations, but in this case, looking at it originally, my thought was I will probably go ahead and restore this with a crown. However, this patient's restoration wasn't very deep axially. A lot of what we're seeing size-wise, it actually wrapped around. So the lingual of the restoration was where it got the majority of the restorative material. So realistically, had that kind of been a mesial or distal facial restoration, I probably would have been able to just restore it with a veneer. But because it wrapped pretty extensively on the distal, I did go ahead and just decide to restore this tooth with a crown. If we look at the bottom left, that first photo, that patient has severe crowding. So anytime I have a patient with severe crowding who is either not a candidate for ortho or is not interested in ortho treatment, we're looking at a crown in order to really kind of get more tooth reduction so we're able to place the teeth exactly where we want them. And lastly, any scenario where I am replacing an existing crown, I'm sure you guys have all had patients who've come and they come in and they say, Doc, I want veneers. You look at their teeth and you're like, you have existing crowns. Like that ship has sailed. But a lot of times patients just know the aesthetic terms and they're like, hey, I don't like what I have right now. I want to look better. I've heard veneers are the answer to that. But, if a patient has a crown, we're restoring with another crown, not a veneer. So as far as the crown preparation, if we look at this tooth in cross section, a crown preparation covers the entire tooth. This is what we're looking for. So the majority of the time that I'm going to go ahead and restore teeth with a crown, the way I'm going to do that is with an all ceramic or zirconia material. And here at Glidewell, I do the majority of my anterior crowns with Brexer Aesthetic. So there are a few guidelines that we want to go ahead and follow when we are preparing the teeth to be fabricated in Brexer Aesthetic. So the first thing you want to do, if we look at letter A, that represents our axial reduction. We want to ensure that we have at least 0.7 to 1.25 millimeters of axial reduction, and you want to ensure that you have clearance. So you want to have clearance in this measurement. A lot of times we've had, or I'm sure you guys have had scenarios specifically with second molars, but sometimes in the anterior as well, when you go ahead and you use like a gauging groove or something and you know I've reduced 1 millimeter, then the patient bites and they're back in contact. That's the difference between clearance and reduction. So you want to ensure that you have occlusal clearance and axial clearance. You want to start to you want to make sure that you're preparing your teeth with a chamfer or a modified shoulder. So you want to make sure that you have nice, adequate bulk of material and a clearly defined margin. You want to have convergent walls. So what I like to look for if I'm doing a full coverage restoration, I like to take a look with my mirror from the occlusal surface and verify that I can see not just the margins, but also all of the walls of the prep. That lets me know that I have convergent walls and no undercuts. And lastly, you want to ensure that you have the 3 planes of reduction. This is very important in aesthetic cases because you want to make sure that you have the proper emergence profile and that your restoration follows the natural contours of the tooth. So you have to ensure that you've adequately reduced along all 3 planes of reduction. So here's an example of what we would look for in an anterior crown prep. We can see that we've got nice rounded internal. Anytime you have a sharper area inside of a crown preparation, that's an area of stress concentration, and you lead to a potential area where the restoration will fail. So you want to make sure that everything is nice and rounded and smooth, and that we can see the full walls circumferentially around the tooth. And when we're looking at posterior crown preps, same thing. Sometimes our more aesthetic cases do go back towards the premolar area, sometimes the first molar, depending upon how large your patient smiles. So what we're looking for with this is the exact same thing. We want to ensure that we've got adequate reduction, that we've got adequate taper with no undercuts. So in the second photo, you can see that we can clearly visualize the margin all the way around the tooth, as well as the walls of the preparation. And everything is nicely rounded out in both of these images. So that's all we're going to cover when it comes to crown preparations. Now the question becomes, when is a veneer more appropriate? So when it comes to veneers, there are a few other things that I'm going to take into consideration. Generally, when we think about veneers, we're just looking at correcting patients' aesthetic concerns. I'm not really trying to do too much structurally with the tooth. I'm not really trying to change too many positions unless we're looking at like minor misalignment, minor spacing. Generally, we're looking at the beauty and the aesthetics of the teeth. So I'm looking to place veneers in areas where structural compromise doesn't really need to be considered and really isn't an issue for these patients. So I'll place veneers if we're trying to improve shade due to like minor fluorosis, minor tetracycline staining, those kind of shade changes, or if patients have chipped teeth, worn teeth, some spacing, but really, again, it's minor things that we're trying to change here. So when it comes to crowns, we really kind of all understand that the only real aesthetic option we're probably considering is a modified zirconia or a ceramic crown. So typically the preparations are the same. But when it comes to veneers, we're looking at 3 different type of preparations. So we have our no prep veneers, our minimal prep veneers, and our conventional prep veneers. And each of these have their own indications of when we would choose one over the other and what kind of modifications we need to do for each. So I'm going to take the time to kind of slow down and go over all that right now. So when we look at our no prep veneers, one of the first things we're looking at is shade change. So with no prep, if I can change the shade by 1 color, I'm going to probably go with a no prep veneer, strictly additive. So if we look at this image here, the red line represents where the enamel is, and then that lighter gray color represents the actual restoration. So with the no prep restoration, you see that we're seated entirely on top of the enamel. We haven't prepped into the enamel, and this is what we will use if we're just trying to brighten the teeth by 1 shade. With a minimal prep restoration, same parameters as far as the colors, you can see that we've slightly prepared into the enamel. And this is used in cases where we're looking to improve the shade by up to 2 shades. And then lastly, with our conventional prep veneers, excuse me, you can see we've prepared fully into the enamel. And this is where we're looking to improve the shade by up to 3 shades. Again, anything more than 3 shades, I am probably going to start to consider a crown. So again, we see this red line is our enamel. And with our no prep veneers, we're seated right on top of the enamel. So these are great because we're able to avoid tooth reduction. On the other hand, they're not really suitable for all cases due to the potential of bulkiness. So I like to use these if patients have slightly lingualized teeth or patients who have a little bit of erosion into their enamel, not too much. So you've seen the patients where they've kind of maybe brush a little too aggressively near the gum line, but all the rest of the enamel is healthy. In those cases, I will rely on a no prep veneer because I'm able to bulk up the restoration or bulk up their tooth without it being too bulky because they're already a little lingualized or missing some tooth structure in that area. So you've got to make sure that if you are planning to utilize a no prep veneer, patient selection is very, very important because you want to avoid having an over contoured restoration. With our minimal prep veneers, we have prepped slightly into the enamel. So we're looking at an enamel removal on the facial of about 0.3 to 0.7 millimeters. So a very, very thin amount of removal. These are great in cases where we have minor discoloration, minor misalignment, and minor chipping. So, for example, we've all had those patients who have kind of chipped off the incisal edge on one of their teeth. The rest of the tooth is fine. You've tried to bond it a few times, but you've had the bonding naturally kind of keeps coming off over time or it's picking up shade. And every time you see the patient, you kind of increase the bevel just a little higher up on the tooth. I find it helpful realistically after a couple of attempts to just go ahead and place a minimal prep veneer. It gives the patient a little more stability and we're not kind of dealing with that restoration chipping off over and over again. And lastly, we have our conventional prep. And so again, this one is prepped into the enamel a little deeper. So we're looking at about a 0.8 to 1.2 millimeter facial reduction, again, following the 3 planes of reduction. To follow the contours of the tooth. So this is for more moderate cases. So if we're having moderate alignment corrections, if patients have diastemas up to about 1 millimeter, we're typically looking at a conventional prep because it gives us more room to really restore and maintain the natural shape of the tooth. And again, color changes up to 3 shades. So this is a little bit more of an extensive preparation, but it allows for greater correction and greater aesthetic improvement. So I know if you guys are anything like me, I love a good flow chart. So I kind of put this together so we can kind of all be aware of what our thought process is. So if we're trying to change the shade 1 shade, we'll go with a no prep veneer. If we're trying to change the shade 2 shades, we'll go with a minimal prep and we're going to prep between 0.3 and 0.7 millimeters into the enamel. And if we are trying to change the shade 3 shades, maybe a little more than 3, we're going to go with a conventional prep and prepping into the enamel between 0.5 and 1.2 millimeters. And so here is our entire flow chart. So once I decide on the amount of preparation that I'm going to utilize, there are other preparation decisions that we really have to make. I like to start by deciding where I'm going to place my margin and what type of margin that I'm going to place. So as far as types of margins that I'm going to place, we've got 3 main options. We have our feather edge, our shoulder, and our chamfer. With a feather edge, I typically do not utilize a feather edge. I find it hard for the lab to really kind of see that margin. It's a little more tricky for them to find and define the margin, which in turn becomes a little more tricky for me to deliver the restoration because there is no apical stop there. You have to be very, very precise when you're seating these restorations. It can be a little tricky. And what often happens in this case, because the margin area ends up being so thin because you've just gone in with that skinny diamond and created that feather edge, the lab has to make the decision between aesthetics and function. So they'll either give you a restoration that is very, very aesthetic, but it's very thin. So you run the risk of that restoration kind of chipping off the margin, or they go with function and they bulk out the restoration just a little bit and you kind of lose a little on the aesthetics. So I find this to be, while it is the most conservative, it can be the most difficult. So I typically will stay away from a feather edge margin. Our second option is a shoulder. The shoulder margin is good because it gives us adequate bulk, so we get a nice thickness of material. However, in order to get that adequate bulk, we do have to reduce a little bit more in this area. So this is the least conservative margin or finish line design, excuse me. This will use a flat-ended tapered diamond. Again, pros and cons. The biggest pro is it is adequate thickness of material, but we do have to reduce in order to get that adequate thickness of material. The finish line I typically rely on the most would be the chamfer. So this is utilizing a round-ended tapered diamond. I typically do the vast majority of my preparations with a chamfer margin anyway. So whether we're talking veneers or crowns, I work with the IO team here, so our in-office team. So I mill a lot of my stuff chairside. And if you are milling, you want to ensure that you are utilizing a burr when you're preparing that's similar in shape to the burr that the mill has. So that way the mill is able to mill and create a restoration that will fit intimately. So our mill utilizes a round-ended tapered diamond. So I utilize a round-ended tapered diamond when I prepare any of my teeth. So I typically go ahead and utilize a chamfer margin. I love a chamfer margin. It gives a nice distinct margin. So if I'm sending it to the lab can see very clearly where this restoration should end. And it gives us adequate bulk and support. But as you can see, when we compare the two images, it is less destructive. We removed less tooth structure to get this chamfer margin. So if I'm choosing a finish line, the vast majority of the time I am going with a chamfer. So after we decide on the type of margin, we have to decide where we're going to place the margin. Our three options are supragingival, equigingival, and subgingival. So with the supragingival margin, it's great for hygiene. Patients are able to really keep that margin area clean. It is less destructive to the tissue, or it's actually not at all any destruction to the tissue because you should not be anywhere near the tissue. Um, so this is good for perio and for health maintenance. The biggest con with this is generally speaking, your patients don't want to see the margin. They don't want to see where the restoration and the tooth meet. So I typically will stay away from a supragingival margin. Our second option is an equigingival margin. I kind of vacillate between equigingival and subgingival. Anytime where I will always choose an equigingival margin is if a patient has a thinner gingival biotype. So if I am concerned that the patient's going to have recession, whether due to me going ahead and sort of touching the tissue when I'm utilizing my burr, or even though it is equigingival, I do still like to pack cord. So if I'm concerned that I might get recession with packing cord, I will stay away. And that's when I'll just choose an equigingival margin. As far as subgingival margins, I find these, I will use them typically 99% of the time, especially in cases where we have deep discoloration that we're trying to mask, or if the preparation just leads me there. So if the patient presents and they already have a little bit of recession and wear in that area, there's already wear on the tooth, which kind of gives us a predefined finish line. Obviously, I'm going to take my margin to where that finish line, which typically is subgingival, or we'll see patients who've had a class 5 composite placed. I'm going to go subgingival, or if there's decay. So if there's some need for me to go there, I will always take my margin subgingival. I also find subgingival margins to be of the most importance in the premolar area. So I typically try to stay away from preparing 6 through 11. I find that it can kind of sometimes look like they've been restored. I like to get a more harmonious look to my restoration. So I like to go premolar to premolar. But with the premolars, you have to remember as the teeth approach the cervical, they get much more narrow. So in order to go ahead and make sure that we're able to follow this natural shape of the restoration, I have to drop my margin subgingival so that the lab has more room to work. So in the premolar area, especially on that distal line angle, I like to make sure that I drop my margin subgingivally. So another flow chart for us. So with our margin placement, supragingival margins with I'll place these in cases where I have no major alignment or contour issues. Equigingival margins, so patients with a thin gingival biotype or peg laterals. And subgingival margins are done in areas of deep discoloration if I'm trying to do any significant contour changes in the premolar region, or also for diastema closure. So with diastema closure, it's kind of that same concept that we talked about with the premolars. You want to ensure that the lab is able to give us a nice emergence profile from the tissue. So I like to drop my margins a little subgingival so that the lab is able to really kind of contour those restorations very well. And so here is our entire flow chart for margin placement. The next decision we have to make is incisal edge design. Incisal edge coverage is a big thing to consider. So we've got four different options here. Our first option is the window prep. With the window prep, I typically do not do this. In fact, I have never done a window prep. This is where we are placing a veneer entirely on the facial. We're not doing anything on the incisal edge. The biggest pro here is that the patient doesn't have to get used to a new bite or new function or anything. There's no adjustment for the patient to have to adapt to. However, that incisal edge can be made a little weaker just by nature of the fact that we've gone ahead and prepared into the facial surface. And it's really not as aesthetically pleasing as if we were to extend just a little further because again, we can possibly see the margin line. So I typically will stay away from the window prep. Our next option is the feather incisal edge. So the veneer covers the entire facial, but also slightly on the incisal edge with a feather of the margin there. So like we talked about before with the finish line, with the feather, anytime we're feathering something out, it's much more difficult for the lab to fabricate the restoration, and it can be a little more difficult for us to go ahead and seat the restoration because again, there is no real definitive stop. So I typically will stay away from this. It's a very technique sensitive way of preparing teeth. And I find that if these are not done correctly, it's very easy to dislodge these restorations during protrusive movement. So I will typically stay away from a feather edge margin. We have our butt joint margin next. So with the butt joint, it covers the incisal edge completely and the veneer meets the tooth at a nice right angle. I find this to be a very durable restoration. We're less prone to chipping. And because it fully covers the incisal edge, we're able to really maximize the translucency of that material, that glass ceramic that we're often using. We're able to get a uniform color and translucency. So I personally like to kind of wrap the majority of my veneer preps. Um, the biggest con is that it does require a bit more tooth reduction there. And you have to make sure that you're very clear with your well-defined margin on the lingual, on the palatal surface, so that you do get that nice match between tooth and restoration. And then our last option is the chamfer. So again, it covers the incisal edge, but it has a chamfer margin on the palatal and not a butt joint. So this one is a really nice mixture. We get the coverage of the incisal edge, so we are able to take advantage of the translucency, but it is less tooth reduction required compared to the butt joint. However, it is a little more technique sensitive. This is a little more of a complicated margin to place, but this is again my preferred margin. I typically like to wrap my veneers, especially if I'm trying to, the number one time I will wrap my veneers is if I'm trying to add length. Obviously, we're going to go ahead and wrap our veneers, or if there's any sort of defect on the incisal edge. So one of the most common question, or really the most common question we get is, do you break contact and when do you break contact? Um, I personally am a fan of breaking contact just because I find that by breaking the contact, we go ahead and give the lab a defined space on either side of the tooth. So when I talk about breaking contact, I'm not always looking at this first photograph where there's clear several millimeters of space between each tooth. Typically, I'm looking more like the second photograph where we see between 7 and 8, where you can just slightly see that light passing through. That's typically what I'm looking at when I talk about breaking contact. So obviously, in cases where we have a class 3 or a class 4 restoration that already exists, we're going to remove all of the restoration. Or if there's decay, we're going to prep to where there is no further decay. And a lot of times that will go ahead and break our contact for us. That's what we see with the first image, excuse me. But even with virgin teeth, I like to go ahead and just get a nice break between the two teeth. I find that breaking contact really helps to hide our interproximal margins, and that's typically where you can tell that someone has had restorative work done. You can see the margin between their tooth and the restoration. But by prepping into that contact, we're able to hide that. Breaking contact is also very, very important in spaces, or prepping into the contact, I should say, is very important in cases where we're trying to close diastema. So if we're closing a diastema, obviously the contact has already been broken, but it's very helpful when you are preparing the teeth to prep into the point where the contact would be. That way, again, the lab is able to fabricate a restoration that takes advantage of adding on both teeth in that contact space. So they're able to bulk both teeth out and not just have one be larger than the other, but they're able to do it into in a natural shape. And I also find that if you are breaking contact, it's typically easier for the patient to keep the area clean. So we start to see less recurrent decay. So again, a couple areas where it's very, very important to break contact is between premolars. So excuse me, between the canine and the premolar, and between premolars, and between premolars and the molar. These are areas where we want to ensure that we have adequate contact open so that we're able to build these restorations. So with the distal of the canine, if you think about the natural shape of that canine, that distal has a nice curve to it. You want to, again, make sure that we're able to have the lab fabricate a restoration that follows that curve. And by breaking that contact, the lab has more room to play with. I personally have always sort of chronically been an underpreparer. I have learned the error of my ways of late. And you just get better results when you give the lab more room to work with. Again, you don't want to over prepare the teeth, but you do want to give the lab enough room. So this is a case where I went ahead and I did my initial preparations, and we have a wonderful assistant, Will, who takes all of our photos. And I went back and looked at the photos, and the first thing that stood out to me was I am very underprepared in this canine to premolar region. So I did have the patient come back and I went ahead and modified these preparations. But I think this photo is very important to show because you can see areas where we should have gone ahead and prepared a little further. And this last tip is one that I picked up from my coworker, Dr. Chi. Whenever you are preparing the most posterior tooth, which again, I like to prepare to the premolar region, I find it very, very helpful to prepare and wrap that distal contact about 1 millimeter past the mesial line angle of the most distal tooth. So in this case, the premolars are the last teeth that I prepared. So I see that mesial buccal line angle on the molar. I like to go ahead and make sure that my finish line is about 1 millimeter into that contact, 1 millimeter past that line angle. That way, we're able to get a nice embrasure there and a nice emergence profile of the restoration. It's able to flow in a nice uniform fashion without looking too bulky in that area. So I always recommend prepping at least 1 millimeter past the line angle of the tooth on that most posterior tooth, excuse me, that we're preparing. So when do we open contacts? Whenever we have spacing concerns. So black triangles, diastemas, and peg laterals. Again, it's all about ensuring that we're preparing past where the contact point would be so the lab has room to kind of bulk up those restorations, taking advantage of both teeth in that contact point and making everything look quite natural. I will also open contact in spaces where patients have crowding. So if we have some overlapping or rotated teeth, you want to ensure again that you've opened up the contact so that the lab is able to work with both teeth in that contact space to correct any misalignment there. And anytime I am changing the width of the tooth or shifting the tooth in a mesial distal fashion, so anytime I'm changing anything mesial distally, open up the contact just so that we have more room to play with and we can kind of adjust things. So whenever we have, for example, if our midlines don't match and I want to kind of shift the upper midline 0.5 millimeter, I will go ahead and prep past that contact point so that we have a little more room to work with. Again, it's all about giving the lab space to do what they can do. So the flow chart of when I choose to open contacts. So now that we've made all of our decisions, it's time to go ahead and start to prepare our teeth. So as far as our preparation procedure, like my father said, failing to plan is planning to fail. So we're going to go ahead and make sure that we're set up to work with everything before we get started. So the first thing I like to do is make sure that my patient is properly isolated. So I like to utilize an Optrogate. This helps to retract the cheeks and the lips so I have a clear field of vision. I will also place an isolite when I do this. So I utilize both. I don't know if I hope all of you guys are using an isolate, but if you're not, it's a bite block, it's a suction, it retracts the tongue, the patient's able to relax, and you're able to just work much faster. I find that I'm able to get more predictable results, and I'm not kind of having to go back and forth and re-prep and touch different teeth. If the patient's fully isolated and relaxed and they don't have to kind of bite and swallow and all of that, this just makes things easier for the patient, makes it easier for us as well. I like to utilize articulating paper. So with veneers, I always want to make sure that where the patient occludes is not where the veneer and the tooth meet. So before I start any preparation, before I put in the isolate, I always have the patient bite on articulating paper so I can mark where their occlusion is. And I use a pencil for that. So I'll have the patient bite, and it gives us a nice bite marks. But then I take a pencil and just kind of run it back and forth, kind of connecting the dots. That way I know I either need to prep above this line or below this line, depending upon the patient's scenario and where it's located. I also like to prep through a mock-up, which I am going to show you in a moment. So I utilize a pencil so that I know how deep I should be preparing all of my teeth. So this is what I like to have set up before I even start anything. As far as burrs, I have a select set of burrs that I like to use when I am preparing for veneer cases. So I like to start with these friction grip depth cutting burrs. Each of these areas with the diamonds are 0.3 millimeters in depth, and it's 1.5 millimeter space between each of these diamond segments. So that way you're able to go ahead and sink the burr at the cervical, the midfacial, and the incisal. And that way you're ensuring that you have at least zero point 0.3 millimeters of depth in each of these areas. And these come in multiple sizes, but the 0.3 is typically where I will start with. We also have a coarse diamond depth marker. I will use this on the incisal. So it gives me about points or gives me 0.6 millimeters in both diameter and length. And I'll just run this across the incisal edge so that I get adequate reduction on the incisal. I then like to use an 850-016 burr. This is my coarse diamond reduction burr. It's a round-ended tapered, so like we talked about, if I am milling chairside for crowns or veneers, or even if I'm sending to the lab, I will use a round-ended tapered diamond. And I use this for any sort of gross reduction. Sometimes I do not use the reduction burrs that I showed. I will actually use this diamond burr to cut gauging grooves along the facial, which I'm going to show in a moment. So I will do this with my coarse diamond burr. I will then go in with an 850-016 fine diamond. And so again, this is the same shape as the previous burr, but it's just a fine diamond. So or finer grit diamond. So I'll use this for any sort of smoothing and finishing when I'm done with my gross preparation. I then use, on occasion, a mosquito burr, and this is just to ensure that I have proper space between the interproximals. So sometimes if I'm milling these restorations chair side, things are close, you have to make sure that you have at least a half millimeter space between the adjacent teeth. So I'll kind of go in with this burr just to ensure that I have adequate space between two teeth. I like to use finishing strips. So like I talked about before, I'm not always trying to see a millimeter, and a half space between adjacent teeth. Sometimes I just want to see that I can see the light passing through. So I will use these interproximal finishing strips to go ahead and just give me that final little bit of space. So it'll kind of remove any unsupported enamel and give us an open contact. And then I also like to utilize soft flex discs as my last step to go ahead and round out any sharp areas. Typically, we see sharp areas during transition. So if we're going from the incisal to the facial, if you don't adequately smooth that out, you'll have a sharp area. So I like to follow these up with soft flex discs just to smooth everything over. So my first step before I begin any of these cases is to get a wax up back from the lab. I utilize a wax up here with our digital treatment planning department. They'll go ahead and send us a printed wax up. I use this for two things. So, one, I will let the patient see it first, but then I will also use this wax up to create a putty matrix. And then with that putty matrix, I can place a mock up. Whenever I use digital treatment planning department and I get a mock up or wax up back, excuse me, I also tend to ask for the lab to send me biotemps. I find that biotemps, especially when they are just one unit, make it much easier for me to temporize these cases long term. They help to give the patient a trial smile. They can wear it for 2 weeks or however long they're going to be temporized so they can see exactly what this is going to feel like in their mouth while they're temporized. And I find that I just get more success and less debondings if I am utilizing a biotemp that spans all the way across. So I will use my wax up to take to create a putty matrix, and then I'll use bisacryl or the acrylic of your choice to create a mock-up. And then I place the mock-up on the patient's teeth, and I place the mock-up in and let the patient kind of try it out, smile in the chair, talk. They do all of this before I numb my patient because I just want them to be able to really see what this is going to look like when they take this smile home before we get them numb and they get any lip drooping or anything. So I like to place the mock-up in. Once the patient is satisfied, then I will go ahead and numb my patient. I find the mock-up is also very helpful because it lets me guide my preparation. So if we take a look, this mock-up is all just one unit. It was all done with the same shade of acrylic, but you can see looking at 8 and 9, we see a little bit more of a bright white compared to looking at the canines. What does that tell me? 8 and 9 are a little bit more of an additive preparation. So I'm going to probably reduce considerably less on 8 and 9 compared to the central or to the canines, excuse me, where we're getting a lot more show through. So that's telling me I'm going to have to prepare a little bit more into the canines than I would on the central. So it's just kind of helping me to guide my preparation. So in this case, like I said, I'm not going to utilize the gauging burr or the depth cutting burr. I'm going to utilize a diamond to place gauging grooves. So following along the planes of the tooth, I like to place one right down the center and then on each of the line angles. So our mesial line angle and our distal line angle. I also, when I place the mock-up, typically will place a small dot of bond before I do this so that it sticks. After I've placed the grooves, I'm going to utilize a pencil to go ahead and mark down those lines. That way I know exactly how deep I'm going to have to prepare. Because as I go in with my coarse diamond burr, you can see it's starting to break off and it's coming off the tooth, even with that little bit of bond. But by keeping those pencil marks, I'm able to see just how deep I need to go ahead with my coarse diamond burr and how far I need to prep. So once I'm done with the coarse diamond, you can see these two teeth that have the mock-up kind of chipped off, the pencil marks are still there. So I know how deep I need to go when I go ahead and refine. I'm not making sure that with my coarse diamond, I get all the pencil marks off entirely. I want to get the majority of it done, but I know that when I go on with my smooth and my finishing, I'll go ahead and remove the remaining marks that are there. So like I said, I will then go ahead and use my finer grit diamond to smooth everything out. And at this point, I'm making sure that all of my pencil marks are gone. So we're just taking that smooth diamond, that fine grit diamond to smooth out our preps. At this point, I like to take my soft flex discs and I'll go ahead and make sure there's no sharp edges. And then I use a perio probe to check my margin. So I'm checking two things with this. Remembering that the perio probe at the tip has a diameter of about 0.5 millimeter, I'll set my perio probe on the margin and without lifting, I'll run the perio probe back and forth along the margin. This tells me one, if there's any area where the probe falls off, I don't have enough depth there. And two, if it's kind of bumpy and jumping as it's going around, it's an area that needs to be smooth. If I can't go smoothly across, the lab is going to have a hard time with creating a restoration that fits intimately. So that just lets me know that's an area I'll need to go back and forth over a little bit more. So once I've done that, I like to pack my cord. I personally utilize a 2-cord technique. So in that, I like to use these cord packing instruments that are serrated to place a small diameter braided cord in the sulcus. So with the first cord, we're looking to get apical pressure on these tissues. After I've placed my first cord, I then go back in with my finer grit diamond just to smooth out the margin. I find that just by placing that first cord, I get just enough apical pressure placed where I can see the margins a little more clearly. And I can go ahead and just refine things right here with that margin a little better exposed. After my first cord has been placed and I have smoothed things out, I will place a second cord. And the key with the second cord, we're looking for lateral retraction of the tissues. So we're not trying to bury. So if we remember how the first cord looked, it was buried, and the second cord is visible all the way around the tooth. We just want to get lateral retraction of the tissue. We are not trying to bury this. If you are someone who is utilizing a single cord technique, this is exactly what you're looking for the same. Lateral retraction of the tissue. We're not looking to bury the cord. At this point, I like to walk away. So I will place both of my cords and then I let the cord sit for 5 minutes to do what they need to do. So I typically, when I was in private practice, this would be a time when I would do a hygiene check or numb my next patient or sometimes just get a cup of coffee, but do something to remove myself from the room. I find that with these larger cases, and the more you're kind of staring at these cases, you kind of lose sight of things. You can't really see any areas that need to be modified. I have found that if I just walk away for 5 minutes, as soon as I come back in, I see something right away that I want to adjust. So just taking the time to let the cord work for you, but also clearing your mind just a little bit is a big help. So once I return, I do my final checks and I just run down these 5 points. I want to ensure that I have proper reduction. Again, I am a chronic underpreparer, so this is number one on my list. I need to make sure I have room for material. Do I have smooth line angles? Do I have smooth surfaces? Do I have a well-defined margin? And are my preps parallel? Parallelism is very important, both with each wall of the prep, but also with each individual prep. It just makes it easier to deliver the final restoration. And at that point, I am ready to take my final impression, whether it's digital or conventional impression. So if I am utilizing a two-quart technique, I do spray a little water to ensure that my cord is moist before I remove it so that I don't have any trauma to the tissue. I then air thin, and I typically rely on a digital impression. And I find a digital impression is very helpful because it helps me really, really take a good look at my restorations and my preparations, excuse me. So what I'm able to do here, because I scanned my mockup and then I scanned my preparations, I'm able to overlay the two. I am able to make the mockup very, very transparent. And then I can rotate my model and look at my preparation from all different angles. And I can see if there is an area that I need to go back in and adjust or smooth, or if I'm not going to have enough thickness of material. So I'm able to really just view it on the screen. Again, I see things that I didn't see before. And this is very, very helpful if you are someone who does not adequately prepare enough or reduce enough tooth structure over time. So here's the patient case we're going to go over. Our last thing, a case where I went ahead and prepared a patient for veneers. So you can see with this case, we're really not trying to change too much on his tooth structure. He's got good bite. You can see our midlines line up. He has a little bit of chipping of the incisal edges. And if we look at the cervical area of number 8 and 9, he was a bit of an aggressive brusher. We have fixed that habit, but you can see there is some wear into enamel there and spacing. And if we look at it from a side view, you can see this pretty big space between his central and his lateral. Lateral is a little small, or excuse me, between his lateral and his canine. His lateral is a little small, so we're just going to try to kind of bulk that out just a little bit. And again, you can see his teeth are considerably lingualized here. So again, that lets us know we're doing a lot of additive work. So he went ahead and prepared his teeth. Because he had a space, a diastema already between 8 and 9, it was important to ensure that when I prepared these teeth, that the final finish line was slightly beyond where their contact point would have been. And if we look at the space between 7 and 8, you can see that we just went ahead and just lightly opened up that contact. I didn't go ahead and create space there of, over a millimeter, but it was just enough space for light to pass through. That way we have a definitive finish line and we'll be able to get a nice embrasure on the facial between those two teeth. And here are his final veneers. So these were restored with Bruxer Radiant, which was our newest iteration of our Bruxer Zirconia. And here is his view from the inside or from the incisal edge. So you can see we've got a nice harmonious flow of these restorations. Again, because his teeth were a little more lingualized, we did bulk things out on the facial, a little more on the central so that we get this nice harmonious flow here. And this is his final restoration. And once again, I do want to point out how important it is to plan ahead. So just as we began with the quote, failing to plan is planning to fail, I'll close by saying that the most beautifully prepared veneers are not just ones that fit perfectly, but they're ones that align with a well-crafted patient-centered treatment plan. So when we approach our work with both precision and purpose, we get not only restorations that are beautiful, but that are radiant, like Brexa Radiant. And that
Dr.
is all I
Brown,
have
that
for
was a
you.
wonderful, wonderful presentation. Really well organized, really, really well illustrated. And I have a lot
Thank
of
you.
excellent questions that I want to go through with you. So what we're going to do is we're going to extend the webinar. Everyone's going to get an hour and a half of CE for this program, and hopefully people will have the time to stick around while you answer some of these really, really excellent and thoughtful questions. Okay.
Okay.
So I did have a bunch of questions about the initial preparation. You showed a patient that had quite a number of interproximal restorations. So I've
Mhm.
got questions. Do you remove all those restorations? Do you always make sure that your preparation ends on two structure rather than
Yes.
composite? Are there times that you do a buildup? Can you just talk to that a little bit? Because that'll cover about three or four of these questions.
So the first thing I do in those cases is I get my ideal preparation. If there is still restorative material there, or same thing when there's decay. If it's still there, I leave it. I get my preparation how I like it, and then I start to clean out all of that restorative material or decay, and I will build up. Um, we use Tycor as our buildup here. It's a resin-based buildup material. And it comes in different shades. So I'll obviously pick the shade that matches closest to the patient's tooth structure, but I don't like to leave old restorative material there. You don't know what's under there.
Right.
We've all had those situations where
Right.
we've
And then
gone
you
ahead.
build it in other words, you build it
Yep,
back up
I'll
to
build it
ideal.
back
You're
up.
not giving the lab a bunch of
No,
undercuts that they have to
no, no,
deal
no,
with.
no, no.
And that also, from what you just said, I take that to mean that you would sometimes have your veneer margin on a composite material, on this buildup material.
I have I have, yes. It's not
Okay.
ideal, but depending upon where we are and what the preparation is looking like, it has happened. But I do keep it when it's on the internal. So not along my finish line, not along my margin. I won't do any of that, but like on the facial surface, I have had restorative material there.
Okay, but in other words, you would not have the margin on
My
restorative
margins
material.
will not. No.
Okay, so if somebody has these Gigundo composite interproximal restorations, that you'd
Well,
have to wrap around. I mean, that becomes a crown,
it
right?
becomes a
If you
crown at that point. Yes.
okay,
Yes.
got it, got it. So what happens if the teeth are very short from grinding and you don't think you have good retention on a crown? Is that just a case where you would just build it up to ideal form?
I will build them up. Yes.
Okay,
And then also consider opening the patient's bite so that we have a little
got
more
it.
room so that we
All
can
the
get like,
questions, they're still coming in. Okay. Um, let's see. What about a scan? You showed scanning. Is there ever a time when you would want to make a physical impression rather than a scan?
the only time I've ever considered it is when there was a little too much bleeding in that area. But realistically, that tells me the tissue is not healthy anyway. So I'll have the patient come back. So no, I always rely on a scan. If
Okay.
yeah.
Yeah, there's so much more you can do with the scan.
Hmm.
Okay. What about, have you ever had a situation where there's sensitivity in the teeth after the procedure? What's your protocol for either preventing it or dealing with it once it happens?
So with every restoration, I always, before I deliver, I treat my teeth with Gluma. So 2 coats of Gluma desensitizer for 2 minutes. It helps with sensitivity, but also studies have shown that it helps to increase bond strength. So I desensitizer on all teeth.
Bluma everywhere.
Yep.
You walk by your operatory, you get covered with it,
Gluma, Gluma.
right? Okay, now after you deliver the case, what are your instructions to the patient as far as precautions? And do you give them a night guard? Do you tell them they can't play football anymore?
100% of my patients get a night guard whenever we're doing any anterior work. And this patient that I actually showed, I gave him his night guard, and then he asked me something about his intramural basketball league, and I was like, "What?" So he also got a sport guard. But I explained to my patient that at this point, these are for aesthetics. So we've got to modify things. Maybe we're not biting into corn on the cob. Maybe we're not biting into ribs. we have to change how we approach things that we're doing. And you also have to have a night guard. So,
Got it. Got it. You showed the two chord technique. Can you
mhm.
tell us what size chords you use for
I
that?
typically will use a 0 or a double zero as my first chord and a 1 for my second chord. But again, it depends on the tissue health. And if we've had clinical attachment loss, you might have to go with a larger chord. But generally, 0, double zero, and a 1.
Okay. And here we have people fact checking. You it looked like on a case you showed, it looked like you didn't break contact with the canines, like you said you do. Do you sometimes
Hmm.
not break
No,
contact?
I will break contact. So some of these photos, the one I believe we're talking about was the one where I had the patient come back because I did have to
Okay,
go in and re-prep. That was once I saw the photos, I realized, whoa, I didn't
got it.
prepare enough.
Yeah, exactly. So yeah, no, in other words, you may not have your initial prep may not have been exactly what you wanted. You take a look at the scan and then you can make modifications.
Hmm. Yes.
Okay. Um, Provisionalization, yeah, you talked about that. Biotemps that are
Hmm.
locked together. I think you were
Hmm.
pretty clear on that. Did you want to say anything else about that?
I add a dot of bond, so a little bit of we use Scotch Bond. It does help to just with retention for those. I know some doctors could try to stay away from that, but
Okay,
I do.
here's a good one. When barely breaking contact, I find it difficult for my scanner to pick up and differentiate the margin. Any tips for that?
Make sure that your scan is very, very dry. So you want to make sure there's no debris, it's dry, and the interproximal strips really do help with that to give you just enough separation that your scanner should be able to pick up on it.
Okay, got it. Got it. Um, what about the incisal design for no prep veneers? I guess that would be no prep.
No prep. They're
Okay.
additive. Yep.
But where do you end the veneer?
At the incisal edge. So at that point, it becomes making sure that you have given your lab detailed information as far as where you want it to end. And
Okay,
then if the patient has wear, sometimes it will wrap. It will be no prep, but it will kind of wrap slightly. It just depends on the scenario that you have. So this is where photos are very helpful and a detailed lab slip.
right, right. I mean, if there's room, you could go ahead
And
and lap
wrap
over
it.
the incisal edge, yeah,
Mhm.
if there's space, yeah. Um, do you use any of your any hemostatic agents in the impression procedure?
With the first cord, sometimes I will soak the cord in hemodent, but I try to not really have cases like that where we're seeing a lot of bleeding of the tissue. I would prefer, honestly, to kind of have the patient return later for a scan. But again, that's my luxury of working here. So in private practice, yes, I was using hemodent on my first cord.
Okay. Yeah, this is a reasonable question. You said you use biotemps to provisionalize, but what if it's just a couple of veneers? How would you provisionalize that? Same
Again,
way?
I find I same way ideally, but I find that having them splinted does give me a little bit more retention. And in those cases, if it's one or two, I am going to really kind of place a little bit more bond than is ideal, which means there's a little bit more cleanup on the back end when the patient comes for delivery. But I find that to just be to give me a little more retention.
Okay. This is a tough question, but it's a good question. When would you use Brux or Aesthetic? When would you use Brux or Radiant? When would you use Emax? Or is there one that
That's
you use all the
an
time?
excellent question. I actually don't use, there's not one that I use all the time. Um, I lately have been placing more Bruxa Radiant. I just really, really like that material. Um, I find that it has an excellent shade match, but I've had great results with all three of them. So I typically kind of, again, at Glidewell have the luxury of just saying, let's try
Right.
Radiant today.
But for example, if you're if
But
you've got a
for
really, really dark stump shade,
then I'm
um,
going to
yeah,
rely on
Brux or
Bruxer.
Aesthetic is a,
I'm going
a
to rely
little
on Bruxer more for
yeah,
that.
a little less
Translucent.
translucent, right?
Mm.
Okay. Peg laterals.
Mhm.
Would you do a veneer for that, or would you just go ahead and crown it?
Um, I have veneered them. Again, it depends on like what exactly our shape is, how much smaller it is than normal, but you get more predictable results if you do place a full coverage crown. Yes, but I have done both. So,
Okay, I'm asking for a friend here.
okay.
Have you ever had slightly open margins around a veneer where it's just not fully flush? Would you use a flowable, or will you just send it back to the lab?
I will send them back to the lab. I have had it happen. I will send them back to the lab. again, just for predictability. And even when I was in private practice, it was the same. My thought process always was, this is not what the patient paid for. The patient paid for a fully sealed restoration. So I want to give them that. So I would send
Okay.
them back.
And do you always temporize a full veneers case? I guess on a no prep, there wouldn't be any
You
need
don't
to,
have to,
yeah,
correct?
but otherwise you would, right?
Otherwise, I do, yes.
Okay. This is an excellent question about cementing or bonding veneers, and I think that's going to be a topic for another webinar. It's a great topic. It's really important. So we're just going to hold that. So I'm sorry, Dr. Farron, for that, but it's a really important topic. We're going to get into it. Night guard that you say you make, do you do it on the opposing arch or on the restored arch? I love these questions.
I typically do it on the restored arch.
Okay,
Yeah.
because the lab already has that.
Right. They have everything ready to go.
Okay. When you're doing a mock-up, what material do you use for the matrix?
For the putty matrix, I
Yeah,
just use putty, or just like
yeah,
the
just
the putty,
your
the chair
regular
side
brush. Yeah.
pressure material. I'm
Okay.
blanking on the words. Yeah.
Okay. A lot of bonding questions. Sorry. You said you prep 1 millimeter into the last tooth contact. You mean you will break contact with a finishing strip between these two teeth? I think that's correct, right?
Mm-hmm. Mm-hmm.
Okay. Um, Great question. What about whitening options? Do you whiten prior to doing veneer treatment? Not those teeth, because you're just gonna prep
We're gonna
away
cut
whatever
them
you
down
whiten.
anyway. Right.
Right.
Right. But the
But
adjacents, yes, so that
but
we
let's
can
let's say
go ahead and
you're
blend.
doing 6 or 8 veneers. Would
Hmm.
you whiten the rest of the mouth
I
and
will.
then
I
match
will
to that?
whiten
Yeah.
the whole thing so that my final shade will
Right.
match the whiten. And then you want to wait, you want to whiten, wait at least 2 weeks before you select the final shade so things can kind of settle a little bit.
Okay. Doesn't having the temps all splint together, doesn't that cause inflammation of the gingiva and lead to bleeding at the time of cementation? Boy,
So
I've
you
been
want to
there.
make it can if you don't have the temps adjusted properly. So you want to make sure they're not like resting on the tissue. And then you have to just have a detailed conversation with your patient about how important home care is while they are temporized. But
Do
I
you ever
mean,
put them
yeah.
on Paradex or something for that
Yes, I have.
week? Yeah.
Yes. And then just kind of rub it around the tissue. Mhm.
Okay. Um,
And I don't typically have them swish with it. Like I said, I'll just use a Q-tip and kind of go around because it can cause staining on the adjacent teeth and it's easy enough to polish it. But yeah, Paradex just
okay.
applied directly.
Question about your email address,
Mhm.
Dr. Danielle Brown at
Danielle, yep,
glidewell.com.
Danielle.brown@glidewell.com.
Okay. Um, Whiter teeth for lower. What material would you use for whiter teeth and lower anteriors?
So I would still use the same materials. So for lower anteriors, I'm perfectly fine with a Brexer Radiant, Brexer Aesthetic, Emax. Yeah, zirconia glass ceramic still for the lowers. And as far as whiter, same materials.
And one of these doctors comments that you're doing such an amazing job answering these rapid fire questions, and I agree.
Thank you. Thank you.
Um, does Glidewell offer a lifetime warranty on the veneers?
Yes, we do. We offer a lifetime warranty on all of our restorations.
Bruxer, all Bruxer.
All
Is it
Bruxer,
all?
Bruxer. Yes,
All,
all
yeah.
Bruxer. All Bruxer, excuse me.
All right. Dr. Brown, you're amazing. Thank you so
Thank you
much.
so
You put
much.
together a fantastic lecture. Really did a good job. I think we got a
Thank you
lot
very
out of it.
much.
We're gonna bring you back. You can show some more cases, and we can go into cementation. I think that'd be a lot of fun.
That sounds
So
great.
thanks everybody. There were really great questions. So thanks for your participation. The panel starring Dr. David Hochberg again was fantastic. Congratulations, Dr. Hochberg, on your 80 over 80 selection. And we will see you guys soon. Take care, and we will see you next week. What do we have next week? We're bringing Randy Resnick back, and he's going to continue his series on occlusion, and he's going to do a special lecture on understanding vertical dimension. I did not think it was possible to understand that, so I'm going to look forward to that. Thanks, everybody. Have a great week. We'll see you next week. Take care.